ఇచ్చి ఏం కాదు ఇచ్చి
చెక్ టెస్ట్
అన్నీ వస్తాయి
మెథాడికల్గా
ఇచ్చేసి అలాగే మాట్లాడు అడుగుతారు.
చెక్. హలో 1 2 3 చెక్. చెక్ 1 మైక్ టెస్ట్ 1 చెక్ చెక్. పీపీటీ ఆన్ చేసేటప్పుడు ఎనీ వన్ ఆఫ్ యూ కెన్ ప్రజెంట్ ఇన్ డీటెయిల్. అంటే ఇట్లాంటి కేసు ఉంది అనుకోండి, ఎవరు చేస్తలేరని ఐఎమ్ ఓన్లీ ప్రజెంటింగ్. ఫస్ట్ పీపీటీ చూపెట్టాకు, ఫస్ట్ మేము వచ్చి మేము గ్రూప్ స్టార్ట్ చేస్తాం. 75 GFR 50 వస్తుంది ఆయనకు. అబ్బా చాలా బాగా వచ్చింది. ఇట్స్ నైస్ కాదా? అని వెళ్దాం. నువ్వు ఇప్పుడే రికార్డ్ చేయకు, మేము చెప్పినప్పుడు రికార్డ్ చేయ. మేమేమో అంత బెస్ట్ మెటీరియల్ అందామా. పార్తా లేనట్టుండు, పిలువు పార్తాను కూడా పిలువు.
ఉంది కదా లాస్ట్ పట్ల
హలో సార్, తొందర వచ్చేయండి, లేట్ అవుతుంది. సార్ కూడా టెన్షన్ పెట్టేస్తే ఎందుకుంది అగ్గుపడుతున్నారు, చాలు అగ్గుపడుతున్నారు అక్కడ బిజినెస్ వచ్చి. బస్ ఇది కూర్చోండి మీరు, యూ కెన్ సిట్ హియర్. ఇదివరకు లేట్ అవుతుంది, స్టార్ట్ చేసేద్దాం. ఓకే అయ్యా కూర్చో. కానీ మధ్యలో ఎవరు రాకుండా పెట్టమనండి, అక్కడ మనీని ఎవరు నన్ను ఉండమని అక్కడ ఎవరిని పిలవండి. నాటు వాళ్ళు పోయి లేదంటే వాళ్ళు లోపల రండి, ఎవరు వచ్చి ముందే రండి. క్లోజ్ చేసాను అలా పడతలేదు. డూ వన్ థింగ్ అటు ఇటు రావచ్చు మీరు. మన చైతన్య పక్కన మన నాకు ప్రాంతం మీద గురు చైతన్య ట్విన్స్ మన అక్కడ దగ్గరికి వేసుకోండి, పర్లేదు. అదే మన ప్రణయ్ ఫంక్షన్కి వచ్చిండు, ఆ రోజు వస్తుండే. ఇట్స్ ఓకే, అవపడతారు కదా సార్, బాగానే అవపడతారు. ఎవరు కట్ అవుతారు? కొంచెం ఇటు చెప్పండి, మీరు అటు ఇటు చెప్పండి, వెనక కూర్చోండి. ఇద్దరి మధ్యలో అవపడతాడు, ఆ ఇద్దరి మధ్యలో అటు ఇటు మూవ్ కాకండి, స్టే వేర్ యు ఆర్. ఒక్క నిమిషం. లైట్ కొంచెం అందరు స్విచ్ ఆఫ్ చేయండి, లేక సైలెంట్ మోడ్ పెట్టండి. రెడీ, ఓకే, స్టార్ట్. గుడ్. Very good morning to all of you. Welcome to our live case transmission from KIMS Sunshine Heart Institute. So let me introduce our group of experts who are working at KIMS Sunshine Heart Institute. So let me introduce first from far right, Dr. Shailendra Singh, very senior and eminent cardiologist, Dr. Vijay Kumar Reddy, senior interventional cardiologist, Dr. P.N. Rao, the chief cardiac surgeon, Dr. Raja Ram, practicing interventional cardiologist at Sunshine only, Dr. Pranay, Dr. Kavya, and Dr. Parthsarathi, Dr. Prashant. So we have a team of one chief cardiac surgeon and cardiologist, and we also have a Dr. Narasimha Rao, cardiac surgeon. So today we are going to showcase a very complex PCA. For this case, we did the right coronary stenting about 10 days back. Then we called him back again for left main PCA. First, let me narrate the case history details. After that, we'll take I'll show the angiogram. Then we'll take the opinion of the experts. This is a 75-year-old gentleman. Known hypertensive and diabetic, presented with he underwent PCF LAD, LCX and RCA, that is in 2012 and 2018. Recent onset of chest pain as with SOB, that is unstable angina of 2 weeks duration.
Trop I elevation.
ECG showed NSTEMI elevation, and echo normal lung function, ejection fraction 60%. So investigation showed nothing remarkable, but GFR is about 55 and elevated Trop I. So let me show the angiogram view. You can see the angiogram. There is a significant osteoproximal LCX disease. Left main appears to be fine, though distally slightly tapered. There may be some plaque. LAD also proximally there is a plaque, but appears to be not very tight. So mid also there is some mild plaque is there, and right coronary CTO. So right coronary dominant, totally occluded from the ostium itself. So with this note, let me have a discussion. Over to Dr. Shailendra Singh. Take this one.
This patient already had triple vessel disease.
Anna, 1 minute. Check. Yeah.
This patient already known case of triple vessel disease. The problem is he has got severe hypertension and severe diabetes, and his lipids were also quite abnormal. And at that time, we had done angioplasty to LAD, RCA, and circumference because patient was reluctant for surgery. Now he has come with significant angina and his Trop I was elevated. So we admitted him and did the angiogram, and the plan angiogram was already presented. The plan would be to just open the RCA first and then go for LM to LCX stenting. That would be the plan. So we did what we did, he will present, but the history is quite classical that the patient has unstable angina. So 2018 was his last angioplasty, and now 2023, 5 years later, he has come with significant unstable angina and Trop I elevation. So that was the plan.
Dr. Vijay Kumar, you can discuss.
Hello, I am Dr. Vijay Kumar Reddy. So this patient is an elderly man and a diabetic with NSTEMI. So we can expect all already previously stented in RCA, LCX and LAD. The osteal RCA is very critical. The calcified almost a subtotal occlusion, which was addressed earliest, and afterwards we have to tackle the later. So here the left main is okay, and there is a osteal circ is the very tight stenosis and calcific lesions. Circ is a very dangerous vessel because the deployment of balloons and stents is very difficult when compared to LAD, because LAD is a fairly straightforward and a straight vessel. So we have to use newer gadgets to address all these things. Always in this type of lesions, imaging is mandatory, especially in elderly patients with calcification already previously stented. Image guidance will give excellent results. That is our plan.
Yeah. Dr. Pierre, you want to discuss anything?
This seems to be a very challenging case since the patient has already underwent twice stenting and he is diabetic. Would have been a good choice for surgery, but he seems to have preferred the stenting. I would like to know that stenting in the presence of this near total or subtotal occlusion of RCA, stenting of the circumflex, how challenging it would be?
Yeah. This case, though there is a very short segment, almost near total occlusion of the osteal, distally, if you see the retrogradely filling nicely PDA, PLV. So what we expected mostly stent restenosis, and at the same time LAD appears to be not that significant. When LAD is not that significant, the patency of the graft is doubtful. So the one option, you can do the functional assessment of the LAD, LCX and RCA, and if the LAD is significant, then CABG is the ideal option. But here, what we expected based upon the angiogram, the LCX osteoproximal, here the most important vessel is right coronary, very dominant. Compared to LCX RCA is very, very dominant. If you open the right coronary, it will give the backup. Now we wanted to assess the IVS, because left main is very short. We can do the OCT also, but sometimes you may not get the ostium very clearly. A very short left main. If it is long left main, that is different. Here, our intention is to take the LCX to LM, assess the plaque burden, mean luminal area, and is there any calcium or not. So if the calcium is there, we will try to go with either IVL or orbital atherectomy, and simultaneously we will also assess the plaque burden, mean luminal areas of the LAD. Is it LAD significant or not? That will determine. So here the onset of angina, NSTEMI 75 plus, and marked obesity, and GFR is a 55. That's the reason we opted for the PCI first option. So Rajaram, you want to comment anything? Do you want to comment? Yeah. All of you can comment about the case.
Seeing the complexity of the case, particularly the LCX, which appears to be from osteoproximal region severely narrowed, and then severely calcified also. Very long segment disease in the LCX, as well as some mild calcium you can see in the proximal LAD. So first initial strategy will be imaging only, then followed by assess the LAD status. Then we have to plan according to the stenting strategy, because LMCA, whether it goes for the two-stent strategy or provisional strategy will be the ideal one. But we should be ready for the surprises in the LAD, what I feel, because it appears to be around borderline region. So still imaging followed by plaque modification is the ideal.
Over to Pranay, you can.
The plan of RCA was already done, so now the plan remains is to tackle the LAD or not. We go with provisional stenting or we go with a bifurcation technique. But the LAD, if we see it is diseased distally also in the distal part of the LAD. So doing an FFR and tackling the distal LAD with DEB, and suppose say FFR comes out to be positive in the proximal part, we go with a two-stent strategy in modifying the plaque with maybe a rotablation or orbital atherectomy or IVL. whichever we decide during the procedure.
Yeah. Kavya?
Sir, just the same thing about significance of the LAD lesion with the FFR, and then if required the 2-stent strategy, nothing much to add.
Partha?
For me, the LAD looks significant because 60 to 70% there is some calcium is there, so it can underestimate the lesion severity also, and also the distal LAD also looks tight for me. So based on the imaging and also the FFR, so we'll decide whether we have to go for a provisional strategy or a 2-stent strategy. So if there is a 2-stent strategy, the decay crush will be the better strategy for that. And also that ostial L6 also there is a tight chunk of calcium is there. So we have to decide based on the imaging whether we have to go for the orbital atherectomy or IVL.
Prashant?
Already we attempted did RCA stenting. Now LCX lesion is significant. Only thing about the LAD, distal is the significant disease is there. Only in the proximal part we have to assess by imaging, and depending upon the imaging, how is the luminal area, how is the compromisation, plaque burden is how much, calcium is there or not. Depending upon that, we have to take a decision about the LAD.
Yeah. Yeah, you can keep it there. Now, in this case, everybody enumerated about the distal LAD lesion. When the distal LAD lesion is there, FFR is not that reliable. What happens is falsely elevate the FFR, the value will be overestimated. So, that's the reason if you are doing FFR, tackle the distal LAD. So, another reason only the proximally, I feel it's not that significant, but distal diffuse disease, even if you put the graft unlikely to be patent. Where they can put the graft, that is very difficult. So here, the IVAS plays a major role. If you want to assess the proximal LAD, FFR is not that reliable based upon the distal disease. So any left main disease, when you address whether you want to do the provisional stenting or 2-stent technique. So only way to decide when you have a borderline lesion or intermediate lesion, take the help of the IVAS. If that mean luminal area is less than 3.5 square mm and plaque burden is more than 65%, definitely patient requires 2-stent. If the LAD shows that plaque burden, requires a 2-stent technique. Otherwise, ideally go with LM to LCX stenting, whether patient requires the plaque modification or not, and subsequently do the optimization of the DES, because left main is the very important crucial area. If you don't optimize the LM stent area, what happens, it can impinge onto the LAD ostium and future MACE rate is very, very high. So that's the reason optimization of the LM stent and LCX stent is, because in LM bifurcation, most common site of recurrence is LCX ostium. Almost if you see the LM bifurcation, 35% of patients, they develop restenosis of the LCX ostium. That's the reason, as Dr. Vijay Kumar Reddy mentioned, imaging is mandatory in this case to see is it adequately expanded, that LCX area, distal, entire stent segment expanded nicely without any maloption, without any medial ejection. That is important. So recently there are studies, many studies have published. One is October trial, Alimony 4 trial, OCTI-IVAS trial, and meta-analysis presented by Dr. Greg Stone. And before that, we have a IVAS based studies like IVAS XPL, and all these studies, ADAPT DS study, and all meta-analysis clearly shown there is significant reduction of stent thrombosis and ISR by 50 to 60%. So this is more so important in left main bifurcation because it supplies the almost 3/4 of the left ventricle. So here we should not compromise with the case. Then I will go to the next. We will discuss about the previous right coronary. This is the right coronary. You can see very clearly. Right coronary total occlusion. We use the Amplatz catheter because we wanted to have a good support. 7 French guiding catheter. By 7 French means we wanted to use like a site unable to antegradally unable to cross dual lumen catheters that can be or simultaneously take the left injection, but we, with a little attempt, we were able to cross the lesion. Fielder XT, using the microcatheter support. Then we placed the Fielder XT. Then pre-dilated, it was very tough lesion, then dilated with 1.25 Riori and graded escalation followed by 2 mm dilatation. So entire stented segment was dilated. Because ISR lesions, OCT shows very clearly what is the reason for stent closure. The clarity of the images are much better compared to the IVUS images. You can see now we have obtained you can see the thick fibrotic plaque even distal to the stent, and stent you can see peristat inflammation. There is a thick fibrotic plaque in some areas of heterogeneous neoatherosclerosis, and this is heterogeneous area, and behind the stent struts you can see the severe deep calcium that led to little underexpansion. So you can see that here you can overlap the stent segments, you can see the more of fibrotic plaque, and this is after balloon dilatation. So post preparation we acquire the images, then I will show the analysis. You can see the thick fibrotic lesion, this is the area of dissection, and you can see behind the stent struts there is significant calcium and there is a peristrat inflammation, and this is some areas showed in this view it is not there, but you can see the peristat inflammation, and this is the deep calcium eccentric behind the stent. So there is significant expansion. Then what we thought, because more of fibrotic and calcium more deep, our intention to try with our Angio sculpt 3x15 scoring balloon. So entire lesion was prepared, and then we used Nagomi stent, Ultimaster Nagomi 3x50 mm stent, just before the distal RCA bifurcation, and then we used the proximal stent 3.5 into 28 mm stent. So this is the check angiogram. Though angiographical is looking fine, but you see how the imaging is going to be helpful. Suppose if you are not using the imaging, you may feel that is absolutely fine, you can leave it. But if you leave it with undetected underexpansion, future restenosis rate is very, very high. Then this is a post dilatation with 3.5 mm OCT, then we acquire the OCT. You see angiographical is looking absolutely fine. So, but if you see the OCT, there is a significant underexpansion in one particular area. So I will show the analysis also. Now relatively, this is the underexpanded area, but remaining areas, the luminal area very good. And I will show the analysis now. Now you can see here 3.9, at least as per the PCA and the European Society of Cardiology guidelines, a recent publication in the EuroPCR guidelines, it should be more than 4.5 in the stent, distal to the stent, proximal to stent. So even EuroPCR also, when the main stent area is more than 4.5, event rate is less. If you are using, it should be more than 5.5. But if suppose if the patient is having a very small caliber vessel, where at least you should see that more than 90% area. But if you see the distally 5.1, and here you can see the 3.8 and 4.7, then proximally very good area 8.9 square mm. Then we thought, then what we thought, because the underexpansion is because the deep calcium, we used the open NC balloon 3x15 mm, that is 35 to 40 atmospheres with guidelines support. See, when there is calcium is there, it's like a cement pipe. Sometimes very difficult to place even balloon also. So open NC we were unable to place, and then we used the guideliner. With the guideline, we use the open NC. You see, we are deeply cannulate, deep, we are placing almost guideliner up to the mid RCA to place the open NC. Now this is after open NC dilatation, this is the final result. So you can see nicely expanded stent and a very good antegrade flow without any flow limiting dissections, PDA and PLV flowing very nicely. So that's the reason always imaging is mandatory in such cases. Now today we are going to showcase the LM assessment by using the IVUS, that is LAT to LM and LCX to LM. Then we will see the plaque. We will also see the what is the plaque component, is it a fibrous, lipid or calcific plaque, whether patient requires any plaque modification, and based upon that we will try to go ahead with provisional stenting or two-stent technique, and post-stenting also. Sometimes what happens is once you put the provisional stent, because the LCX, once you expand it, it may push the carina toward the LAD. That time also reassess the LAD ostium, any dissection or intramural hematoma extending into the LAD, and post-provisional stenting, LAD ostium should be good without any dissection, without any IMH. So mean luminal area should be good. Otherwise, we will proceed with the T-tap stent. This is our strategy. And finally, I will ask Dr. Vijay Kumar Reddy to say a few words, and we will have a discussion with Dr. Shailanti. Then we will proceed with the case. Meanwhile, you can start any one of you can go and start the case, and Rajara Veltara, you can proceed. Radial, slender sheath, and use the, we can take JL because short left main. Short left main, very short left main.
So there is a nice case demonstration of RCA, which is tightly calcified, almost a subtotal occlusion, which was how we can see the imaging helps in this case. Suppose if you don't do imaging, the mid portion of the RCA is only underexpanded, and you may think it's angiographically a good lesion, but after 6 months or 1 year down the line, you may come with instant stenosis. So because of this, imaging is very good modality, especially in calcific lesions and complex lesions. And there is all the recent data like October trial, all this showing the event rates. They are very much less when compared to angiographically driven interventions. Now the plan was to assess the left main and do the LMCA to IVL, this LCX lesion. So LCX is very difficult, though it supplies only 20% of the this thing, but it is for interventional cardiologists, L6 is very difficult vessel because of its AV groove location, all these things. And most of the times you may require, especially if it is a calcified, you may require some backups like good guide support and guideliner support, all those things. So here, I think after imaging, we have to plan. The initial plan was to do imaging and put a LMCA and LCX stent and assess the expansion, all those things. Now, I will ask Dr. Shailandra.
Here, because it's an osteal circ, there is a high incidence of recurrence.
Plaque modification device.
What is the kind of stent plaque modification is necessary for majority of patients with LCX RCA lesion? Because it is very important to use, even if it is non-calcified, you have to use a cutting balloon. If it is calcified, then you may require some additional plaque modification like IVL or ROTA or anything of like in those choice. But if there is, what is the stent that would be ideal? I'd like to ask Dr. Sridhar, what would be the ideal stent to do a stent with the thin struts or with a slightly thicker struts to treat the osteal LCX lesion?
There are some case reports and bench test trials from Japan. They have shown, they presented in TCT. Actually, calcified lesions, left main, usually you should have a stent with sufficient radial strength, and usually they compared with, I don't want to mention the name, Science with other stent, which is very, very thin strut. But the deformation of the stent is more with other stent. But Science definitely, we prefer in calcified vessels. Calcific vessels, where the left main, you should have a good radial strength. So that's the reason. Any stent with a good radial strength, and when you are doing the left main bifurcation, the cell side should be good. When the cell size is good, crossing the side branch. Now, of course, all the latest stents are having a more than 3+ the cell size. So that is also very important. And how many links are also important. If the more the links, then one advantage, more the links, it will give the more radial support. But at the same time, more links across the LCX osteum. Then again, the stent osteum across the LCX osteum, there may be tissue growth. So double ostia, everything will be there. So that's the reason the stent should be relatively less. Now almost only 2 and 3. Previous version is Taxus is 6 links. But now hardly 2 and 3 links only. But any stent is useful, but I prefer a stent with a slightly thicker and slightly more radial strength. You want to say?
As rightly pointed out by Dr. Sridhar Kasturi garu, most important thing is the presence of radial strength. Apart from that, I feel the second most important thing is usually there is a disparity, there is a mismatch between the left main and the LAD or a LCX. So you have to choose a stent where it can be upgraded, expanded. For example, there are 2 stents recently, this Ultimas or Nagomi has this 3 stent can be expanded up to 6. So the optimization in the left main is excellent. Another stent, of course, and still it is not available, that is Synergy, what is that? That Synergy stent? Megatron. That is also, we can expand up to 6 mm. So these are the 2. So expansibility of the stent in the left main in case of that is also most important. And the third thing is links. These are the 3 essential things. If you think radial strength is not good, for example, if you take this earlier that bioabsorbable stent where they don't have any much radial strength, they are not ideal for calcific lesions.
Anything you want to add?
Sir, looking at the calcific this thing and 75-year-old male, what would be the best plaque modification therapy and safe to avoid complication in such a difficult case?
What kind of plaque modification device you are going to choose is very, very important, essential here. I don't want to use rota for this patient. Why? Because very easy to do it. LM to LAD and LCX you can do it. But here distal LAD is deceased. So when debris goes, and most of the time debris can cause, when in the presence of distal LAD disease, it can cause this, because smudging, that can lead to slow flow, no flow phenomena. Of course, here the advantage, we have opened a right coronary. So it's very safe only. But I anticipate slow flow, no flow phenomena in the presence of distal LAD disease. And relatively no flow phenomena, slow flow is less with orbital atherectomy, because the microparticle it generates is only 2 microns versus 7 to 10 microns with a rota. And another one is if the deep cap, the left main area is big, it's a 4.5. So even if you use the 2 burr also, that may not cause adequate plaque modification, particularly in the presence of deep calcium. Okay, only superficial calcium, if you shave it, that's fine. Now we are saying only plaque modification, subsequently modify it, that's enough. That's also fine. But here in the presence of the distal LAD disease, I'll be reluctant to use to avoid this low flow, no flow. Another one is IVL. Advantage of IVL, even you have a 3.5 4 mm balloon. So it can, even LM, it can modify very nicely. LCX it can modify, and LAD it can modify. The only thing is here, if you are the LCX is 3 mm, LM is about 4. That time there will be a size disparity. So in such cases, but we are going to use only 4 atmosphere, the chance of dissection, flow limiting dissection are very, very low. IVL is very safe among the 3 devices. The effectiveness of the modification is very, very good, because even eccentric, calcium nodule or concentric lesions, disrupt studies have shown very useful in all subset of calciums. But deep calcium, only IVL plays a role. Orbital, and this orbital can cause the superficial, even deep shaving, even deep. But rota mainly superficial calcium. And eccentric nodule again orbital, because it moves along. Suppose I will show the calcium nodule, I will prefer orbital atherectomy over the rota ablation. I don't mind using the orbital IVL also, because IVL it can cover the total circumference of the vessel. It can touch the entire circumferential, but only thing you have to give more pulses when the eccentric is there. So requirement. Another thing is sometimes what happens in eccentric calcium or severe calcium, it can cause the balloon rupture. So you have to be mentally prepared. Though it's not a lethal complication, but you have to use another device. The device costs 3.5 lakhs. If you are using second one, it will go to 7 lakhs. That you have to consider. And always, suppose if the imaging catheter is going freely, then IVL can go. If the imaging catheter is not going, very difficult lesion, eccentric lesion, even with guideline it may not cross. See the behavior with the balloon, see the behavior of the lesion with the IVS catheter. If you are able to track this nicely, then you can use the IVS. Suppose uncrossable lesion, only way either do the rota or orbital atherectomy. After that is still inadequate, you can add a cutting balloon, or you can use the open NC, or you can use the IVL as a second option, like a rotatripsy or orbital plus IVL option. If the thick calcium is there, sometimes single device is not adequate. You have to give a combined strategy.
There is a simple balloon uncrossable, rota or orbital, balloon crossable, IVL. This is the simple flowchart. The advantage of IVL is there is a very short learning curve and it is easy to be done. These are the two advantages. But the thing is only it is slightly expensive, but all the three modalities, orbital, IVL, rota, they are very much useful in the plaque modification in the calcific lesions. Without these gadgets, it's very difficult to achieve the luminal gain, and stent thrombosis and stent under expansion is a very common unless you use this gadget.
Another thing we used to do olden days, I mean, we used to do ostial stenosis with ostial stents. We used to just put the stent just beyond the ostium in the left main little bit and then put the stent. That is given up now. It is not at all good. You have to do a good crossover stent.
Yeah. So I have one doubt. So suppose we do an image and we find that there is a tram track calcification, heavy calcification, we modify the plaque with say orbital atherectomy, we achieve a good luminal area. So instead of going for stent, we can come out doing a DEB and coming out with that. That would be an option for us.
Actually, that is also now the recent Deodalis registry, where they compared DEB versus DES. This is one of the largest registry. So they have shown non-inferior results with the DEB. It's not superior, but particularly complex calcified lesions. Even if you more studies from the Japan, they are using calcified LCX, they are using the rota or orbital and plaque modification or IVL, subsequently apply the DEB, come out. They are finding a very good results. Ultimately in calcium lesions, you have to achieve the luminal area, adequately modify. If the good luminal area is there, DEB works very well. But lesion preparation is very important key for DEB application. Before you apply the DEB, you should have a good luminal area, adequate plaque modification, there should not be any flow limiting resection, and the residual stress should be less than 30%. So ACC has given a recent, if you see the JOC, recently they have published one article, that is third consensus report. So imaging and FFR is mandatory while doing DEB. Don't use the DEB for lesion preparation. Adequate lesion preparation, if the only fibrous, you can use the cutting balloons. If it is calcium, use any plaque modification device. Get the adequate luminal area without any flow limiting dissections, without any residual, apply DEB and come out. And still, if you are angiographical, if the reason appears to be suboptimal, use the FFR. If the FFR is more than 0.87, leave it. Otherwise, take the IVS or OCT. Luminal area is adequate or not, without any dissections. So that time you can leave it, they will have very good results. But without imaging, without FFR optimization, you should not do DEB, because you are not putting the stent, you don't apply the high pressures. If you hypen it, the dissections are more common. Right? Now we will go to the case, and all of you can watch, and during While doing case, we will have a interaction with Dr. Shailendra Singh and Vijay Kumar. We will take their inputs and we will continue. I think this would be very nice case because the LCX RCA, whether to go with the proximal LM to LC provisional stenting or two stent technique. Distally also LAD will try to dilate with a small balloon. If needed, we will try to put the DEB. Thank you, one and all. దానికి వెయిట్ చేయకండి, టైం వేస్ట్ చేయకు. దానికో మళ్ళీ 5 నిమిషాలు. I need 2 wires, one BMW, one run through. Now we are starting the live case demonstration. You can see the left main, there is a distal tapering compared to the proximal. Distal, there is a definite significant block is there, and if you see the LCX is very tight, osteoproximal lesion, very tight lesion, and LED also there is a considerable block burden. Go to the next view. Now you see the just after septal there is significant lesion, and this entire vessel is severely calcified. You can see the LCX and LED both. You can see before injecting the contrast, the calcium is seen on both sides of the vessel wall and more than 25 mm. You see the entire LED is calcified before injection, proximal mid. So long segment calcified lesion, even LCX also significant. There is a stent is also there, but beyond stent and proximally also we are able to see the calcium block, and LCX ostium also calcified. So now we will assess the IVAS assessment of the LCX first, then we will see the entire LED, and really LED requires or not. Angiographical I feel he requires the 2 stent technique. Now we are putting the HD IVAS catheter into the LCX. Come. Show me the next view also, LED distal. We can see the distal LED as significantly diseased and diffuse long segment lesion of the proximal to mid. Relatively distal LED appears to be fine, but at the apex again there is significant disease. Come nearer. Is Ona? Okay, table come to PA cadal, LCX. So always when there is a tight calcific lesion is there, you see the when you are passing the IVAS, are we able to cross with IVAS catheter? That is very important. If we are unable to cross with L, then you can use the IVL. Otherwise, you have to use the rota or orbital atherectomy per plaque, like uncrossable lesion. So I am going to as distal as possible. This is LCX. Yes. Now we will take from here. Yeah, we will take from here. You can take the IVAS study. Brother, show me the monitor. Turn this side. Just this monitor, can you keep slightly away or pull your side? Record continuously. Now you can run the IVAS run. You can distally, there is no significant block. You can see the trilayer structure, you can see luminal area very good. There is no significant block burden. This is from the distal LCX. Continuously purge. So we are able to see borders very clearly, very good IVAS images. You can see the trilayer, no block burden distally. Then I will pull, then make it somehow it's not we are not getting automated run. Ready, manual? Shall I pull? Okay. Now I am pulling. You see now here also there is no plaque burden. See trilayer structure, no plaque, and we are coming proximally. Here some plaque is appearing. You can see now. You can take the there is the some plaque burden. There is a plaque burden. And there is a branch. You can see the small branch. Some calcium is there. You can see the eccentric calcium, and you can see here again here also some eccentric, but luminal area is good. Here also calcium is there. You can see now calcium almost 270 degrees, thick calcium. Luminal area you can see only, I can say 2, diameter is only 2 mm. There is a significant calcium. You can see this is the previous stented segment. Now you can come proximally. Now coming to the proximal to the stent. Now I am going distally. There is a calcium, again calcium. Now I am pulling back into the LCX. You can see the ostium of the LCX. That is LED. See severe LCX ostium, very severe plaque. but more of fibrotic plaque. You see, the very tight. Here calcium is there. You can see the ostium of the LCX is severe calcium. That is the LAD. You can see the wire in the LAD. So this is the LCX ostium. LCX ostium is severely calcified. You can see almost 270 degrees. Eccentric plaque, and you can see this is the eccentric plaque. Now I am pulling it to the left main. Left main also calcification is there. Almost a 300 degree calcium is there. Now we are coming into, because you can see the LMCA. Though distal LMCA diseased, but more importantly LCX LCX ostium is significant calcium, and previously stented segment also diseased, and slightly distal to the stent also there is some disease. Give the IVL, brother. We'll do the then we'll do the LAD. After that we'll go with IVL 3. 1 minute. 1 minute. Let me. Previous LCX view show, is it in the OM branch or in the distal? Sir, severe calcium. 3. Severe calcium. Sir, LED also severely disabled. Balloon itself not going, old balloon. Grating sensation is there. But anyway, I will do the IVL. Branch it. Okay, right. LED మీద ఇచ్చేయండి IVS. Now we will acquire the IVS study of the LAD. Yeah, Angio LAD also requires, even behavior of the balloon is not good. Grating, difficulty to place. It will be severe. Come nearer. Come nearer. Nearer. 1 minute. 1 minute. Come now. Already we have gone inside. Come. Flora. Come. Dagrama. You see here, you see lot of resistance. Where we are suspecting, see this is a uncrossable lesion only. See na? We are unable to place the IVS catheter. It's not going beyond. You understood? Na? That means it's a balloon uncrossable lesion only. I can Ranjay, brother. So we are unable to cross that mid-LED lesion beyond that segment. Run. Manual error, Babu. Run. Inject. See, there is severe calcium, almost 360 degrees, thick calcium, and almost 360 degrees. See, that's why we suspected there is severe. See, severe block burden, calcium, even LED ostium also severely calcified. That is L6. Now distal left main. Now, what is the option now? We have to do the orbital or rota only. I think we will go with orbital for this case. I will discuss with orbital because uncrossable. IVS is not going. We will do orbital of the LAD. LAD much more severe. So we will do the orbital of the LAD. Then we will go to the L6 orbital. Then we will go with L6. Prepare the orbital atherectomy. Show me the previous all views, brother. LAD. We will analyze again. See, distal left main tapered. Though LCX is showing the plaque, but appears to be stent is not that tight. But ostial LCX definitely severe disease, and LAD that after septal we are unable to cross that segment with IVS catheter. That means it's a very and a severe 360 degrees calcium and a very thick calcium. So we use the orbital atherectomy for this case. Go to the previous. You can see here. Here also, you see angiogram so deceptive. In this view, it is not appears to be that tight, but another way it is tight. But we were what I suspected while passing the 1.5 balloon also, we were unable to cross, while passing also grating sensation. There was difficulty in crossing. So orbital will do, then subsequently if needed NC balloon dilatation, we will acquire the IVS, then we will go with the 2 stent technique. Yeah. Faster the better orbital. So here while they are preparing orbital atherectomy, let us discuss about the different modification devices because we don't want to keep it blank. So here diffuse disease of the LAD and LCX. So LAD uncrossable lesion, that is the reason we are not going ahead with the IVL. Initial strategy was to go with IVL plaque modification, but even IVS catheter is unable to cross. So when we are unable to cross with IVS catheters, the best modality either you can go with the rota or you can go with the orbital. Here why we are preferring the orbital, because the thick calcium is there and very severe calcium. We wanted to use both LCX and LAD, and distal LAD diffuse disease. When the distal LAD diffuse disease, we anticipate some slow flow, no flow. So that is the reason the slow flow, no flow is slightly lesser with the orbital atherectomy, and it cuts the, even LCX RCA is eccentric calcium. It cuts the LCX eccentric calcium more effectively. That is the reason we are opting for orbital atherectomy. So particle generation is very small, 2 microns versus 7 to 10 microns, and during cutting there is a continuous forward flow in orbital, whereas in rota there will not be any forward flow. So because of that, the flushing of the whatever debris are not there, less effective. And at the same time, when you are using the orbital atherectomy, you can do forward cutting and backward cutting. So whereas rota only forward cutting, sometimes what happens, it may suddenly jump beyond the lesion and it may cause the burr entrapment, and those instances are more like a burr entrapment or burr dislodgement, stall burr. So but at the same time, orbital atherectomy, forward and backward cutting, even if you cross the tightest lesion, you can pull and do the backward cutting. That is the advantage. So backward cutting, forward cutting maintains the forward flow, and slow flow, no flow is less likely, and eccentric calcium is more. And the larger the vessel, the effectiveness of the orbital atherectomy much more compared to rotal. So like it can ablate the even left main also more, 2.5 to 4 vessel, it can more effectively do the plaque modification. And single burr level the rota. So suppose if you are using the LAD rota, then LMCA you may require bigger burr, 2 mm. Here you can use single burr, increase the speed, 80,000 versus 1 1,20,000. So you can larger vessel when proximally you can see the tapered, proximally much bigger, distally. So that is the reason we wanted to choose the orbital atherectomy in this case. One is eccentric calcium, one is the asymmetry of the lesion, estimate tapered vessel, another one is slow flow, no flow due to distal disease, and more effective ablation. Pardon? Side branch, only IVL. IV fluid. We have to remove one wire. LCX wire తీసేస్తా. No, ఆర్బిటల్ యూజ్ చేయరా. దిస్ ఈజ్ ఎల్సెక్స్. ముందే వేసినాక పుల్ చేస్తలేండి. కీప్ ఇట్ దే. కీప్ ఇది వైపర్ వైర్. వైర్ వచ్చిందా? కింద ఇప్పుడు వైర్ చూపెట్టు. యా ఫైన్. ఏ బ్రదర్ డిజిటల్ టిప్ చూపెట్టు. Got it? Pull the wire, slide, bas. Leave it there. On never. We'll go as distal as possible. Right, remove. Give me the wiper wire. Now we are exchanging the run through with Viper wire using the microcatheter. Microcatheter we placed too distally. Why? Because there was a difficulty in placing the wire. That's the reason we kept the micro as distal as possible. Then go push, no problem. We are inside. Okay. Still go ahead. To show the tip, yaar. Now this is enough. Pull the, remove it. Come. Pull. Okay, still, right. Okay. Put immediately orbital. Brother, orbital connected, huh? Can you show the bar tip? Once we come here, then I'll show the bar tip. Brother, come here. You can zoom, na? This one. Now this is the orbital atherectomy crown. You see, this is eccentrically mounted. That is, you can see, na? This is the elliptical shaped crown. This is the elliptical shaped crown. Whereas a rota, it will have a bullet shape. The proximal half is studded with the diamond chips. Nearly 2000 diamond chips embedded, 2/3 inside, 1/3 outside. And see, because the proximal half is studded with the diamond, whereas the distal half is free. So that's the reason only during forward, like a only rotational movement, that is, this is centripetal. This moves along the periphery of the vessel circumference. So that's the reason. Now you can see very clearly, just we can operate. Wire came out, 1 minute, I will put the wire. Pull the wire slightly, pull the wire. Now is it okay? Right. Then I'll slightly pull, we will show the bar moment. Keep it here. We have to block, move it back. Now this is break Ashira. I will show the brother. You have to show here. Brother, is it dyna or regular? You say, is it 80,000? This is 80,000. Yeah. Now you can see the very clearly that bar moment. Now this is the when you want to start the orbital atherectomy, turn this angle and press it, move it. Once you press it, and this is locking and unlocking of the bar. And then now you can have, this is the 80,000. This is 1,20,000 speed. So high speed ablation, if you want, 1,20,000. This is 80,000 revolutions per minute. So this is the dynaglide mode. And then dynaglide, press 1 minute. Press this one, you press. It will blink. Continuous press. Okay, 1 minute. Press. Now it's a dynaglide. So this is the dynaglide. While placing the orbital atherectomy inside the catheter, you can put the dynaglide. So I will go with the dynaglide mode. Hold the wire, break, remove the brake. It's like a passing over the wire. Pull the wire. Yeah, I am going now. Now you can, right. Now you can, pull the wire slightly. That's enough. Paina catheter tip chupettu, show the catheter tip. Yeah. Just remove the zoom. If you press this one, continuously press. Press. It will go free. This one press. Then press. You press this. I'll go. Press. No. You have to rotate and right. Show me the catheter tip. Slightly move this side. Yeah. Hold the wire. See that catheter is well placed or not. Come now. Further. Come. Just 1 minute. Show me the.
It is in guide, sir.
Come nearer. Yeah. Still come nearer. Come nearer. Now it's reached. Yeah. You can see now. Come to yellow caudal. Then yellow caudal. This one. That we press. Table. Brother, I am unable to see that one. The regular 80,000. Fluoro. Now our orbital atherectomy is at the left main. So now we will start. We have to remove the second wire. While doing orbital atherectomy, don't use because it can cut the second wire. I am removing this. That is the advantage of using IVL. When you are using the IVL, you can keep the side branch wire. While doing rota and orbital atherectomy, you have to remove the side branch. Otherwise, it can fracture the side branch wire. Now I will go ahead with the. Brother, time chusko. You have to go slowly, 1 to 2 mm, just forward and backward motion. Stay there for some time. 25 seconds, just see. It will show beep. Yeah. Once it is over, then lock in. How many seconds? Okay. You have to go very slowly, 1 to 3 mm at a time, forward and backward. Now I am doing only proximal LAD and distal LMCA. This is the tightest area. Come to epicranial or arrowcranial. After that, if you want to demonstrate, you can demonstrate also. Show me this one. Come. Yeah. Here we will do again that over. Shall I proceed? This is the area of tightest lesion. You understood now? This is the area of tight. See, crossed. More you keep, more ablation will be there. ECG, pressure, everything is fine.
Just for the sake of discussion, after the orbital atherectomy. You want to assess the region whether it is dilatable or not. How do you go about it, sir?
Yeah.
You want to go with the NC or you want to directly go with the IVL
Yeah.
combination?
ఏమైంది? 1 minute. Why? Stop అయింది. Power off? No, power off అయినట్టుంది. No, it's not coming కదా. No, light పోయింది అక్కడ. Orbital atherectomy. Now you press again. It's not. Now it's fine. ఇది ఒకటి. That's fine. That's fine. రెడీయా? Senior. Now what I will do with the dynaglide will slightly advance. Break off. Remove the brake. Then press multiple times. Now it's a dynaglide. Hold the wire. Remove the brake. I will go forward. It's okay. No brake off ఉంది కదా, అది ఆఫ్ చేసి దీన్ని ప్రెస్ చేసు, ఇది ప్రెస్ చేసి పెట్టు. యూ ప్రెస్. యా రైట్. ఇంకా ఫార్వర్డ్ పెట్టాలి. రైట్, దట్స్ ఫైన్. రైట్. No, this one. We'll switch on to this one. No, switch on to this one. Now it's right. Okay. Now we are doing the mid to distal LED. Rajaram just now asked one question. So whenever you do the plaque modification, post plaque modification, do the imaging. If you see the fractures, if there is a gain in the luminal area, or if you see some dissections, that means you have done the, and also you see the thickness of the calcium. If the calcium thickness less than 0.5 mm and gain in the luminal area and fractures, then no need to go for further upsizing or another device. Otherwise you can, suppose if still inadequate, you can use the cutting balloon or angio sculpt or high pressure NC. Again repeat IVUS, whether fractures are there or not. If fractures are there, means it is adequate modification. Then you can go ahead with the stenting. Ready, brother? I think this length is enough. That area is the tightest. I can remove it now.
For the sake of discussion, we have seen only IVUS. In IVUS only superficial calcium we can assess, but arc and all those things. But thickness it is very difficult to assess. So we have done the orbital atherectomy, but we don't know what is the thickness of the calcium.
That is in
case, what would be your choice? Whether you want to second imaging, whether you want to do OCT and then confirm the thickness, or you want to do the plaque, how it is behaving with the NC balloon.
Normally deep calcium is there, it shows the reverberations. So back side you will have a extra reverberations you can see very clearly, and at the same time if the fractures are seen, gain in the middle, no need, you can straight away go ahead. I think we will take one small injection, we will see the forward flow. Ready, Amiru? Yeah, good, Sini. Inject. I think flowing well. 1 minute. Let me engage. 1 minute. Small test. We'll take adequate injection. Small test. Okay. Ready, Miru? It's okay. We'll take one scene. Yeah. Inject. Bye. See, it's flowing well. What our target? High polishing runs like a 1,20,000 up to that, beyond that diagonal. That's fine, I think. Now reasonably good. We'll go with a 1,20,000, 2 runs. Then after that, distal if needed, we'll try to do with a small balloon dilatations. You just move to this one. Now we are going ahead with a 120. And a discomfort unda? Small 1 cc, give 1 cc. Ready? Even good in here. Cool, flowing good. Miss any good. It's okay. This is good. We'll do one more run and we'll come out. Just maintain fluids, brother. This area is more. And then we'll come out. Break open. Pull slightly into the catheter. After that, we'll hold the wire. No, after that we'll put it in there. Push. Then push this. Yeah. Now you push the wire and pull out. Wire పెట్టుకుంటే లాగండి. No, అక్కడ ఎక్కువసేపు ఉంచొద్దు. Push the wire and pull out. That's it. Push the wire and pull out. Push. Hurry అట్లాడు. Wire వస్తుంది. Push the wire. మీరు అందుకే push. No. పర్లేదు ఎవరినో నేమ్ అనుకోకండి. లీవ్ ఇట్. దోస్ ఆర్ స్మాల్ థింగ్స్. ఎవ్రీథింగ్ అండర్ అవర్ కంట్రోల్. పుల్ అవుట్. వైర్ వేసుకుంటే పుల్ చేసేయండి. యూ డూ ఇట్, డోంట్ వరీ. పుల్. పుష్ ద వైర్. పుష్ అండ్ పుల్ ఇట్. పుష్ ద వైర్. కీప్ దట్ వైర్ ఇన్ దట్ ప్లేస్. Push. Still. ఇంకా రావాలి. Out. Right. Remote. Give me IVS catheter. IVS catheter. ఇచ్చేయండి. దేని మీద చేసేదాన్ని. It will go. We'll do the orbital of the L6, then we'll go with the stenting. Otherwise, the mid to distal we can stent it. Proximal LM, proximal LAD we'll do after orbital. Now we did the orbital atherectomy of the proximal to almost distal LAD, and now we are taking the IVS images, mainly to see are we able to place the IVS distally, and mean liminal gain is there, any fractures are there or not. Come nearer. Come. Fluoro. ఆయనతోటి మాట్లాడండి ఎవరైనా. అరే బాబు, అష్యూర్ ఏం భయం లేదు, డోంట్ వరీ.
అన్ని బాగున్నాయి సార్, అన్ని పర్ఫెక్ట్గా ఉన్నది.
ఒకసారి దగ్గర పెట్టండి. రైట్, ఒకటే. ఇప్పుడు ఇన్ని తీసుకోండి. రెడీ బ్రదర్? మాన్యువల్, ఓకే. ఆన్ మాన్యువల్. షో మీ, అరే బాబు, షో దిస్ సైడ్. We can see, now I am pulling manually. Now you can see there is eccentric lesion. Calcium you can see very clearly. You can see the fracture there. Here also you can see the fracture. You can see, na? That is the fracture. Break. I will show the again. There is a definite luminal gain is also there. So those are the fractures. You can see the discontinuity. Where is our catheter? Now LED osteum. Even LED also now looking much bigger. You can see now compared to earlier. I think this is adequate plaque modification. No need to do anything. Yeah. Wait. Right. Give me. We'll place the regular wire. Give a term microcatheter. We'll exchange the Vine, sir. Now we are able to place IVS catheter also. Microcatheter. What I will do LCX modification, then implant the stent. LED wire అవసరం లేదు అందుకే. We'll do. Give another wire, I will tell you. Give another wire. I will put the wire into LCX and I will take out. Take one cine before removing the wire. LED, let us see. Ready, Amir? Brother, show me. No, let it be there. Don't worry. Go ahead. Inject. Right, that is fine. Appears to be good. Now let us place the Ivama. Give me run through. Brother, yellow caudal, come to yellow caudal. Just now see the injection. Is it engaged or not, Rajaram? Now it there. Give me the wire. J is there, huh? Come. P.A. Caudal. Show me the injection. Are we in the right place or not? I think we have to go this direction. Fluoro, small injection. And this is right. This is right. That's fine. Give. And take out this. Again, you have to put the vapor. Microcatheter. We finished the orbital atherectomy of the LED. Now we are proceeding with the orbital atherectomy of the distal left main and LCX. Hold it. Show me the tip of the wire. That's enough. Let me know once you get the distal. I think you may get it. Hold, pull, slightly pull. Pull, make it straight wire. pull the wire, make it straight. Give me that one, wiper. Brother, give me one Angio sculpt, 3 mm. ఇది అయిన తర్వాత I will do plaque modification with Angio sculpt. Further modification. Yeah, go ahead. Go, show me. Push inside micro kada. Push. Go ahead. Go. Go ahead. Yeah, remove it. Pull. No, micro catheter is there. Huh? What is that black one? Still. Right. Yeah, got it. Brother, give me orbital, clean completely. Wipe the wire. Extensive disease. Actually, angiographical appears to be. And frankly, that is also too tight, unable to cross with IVS catheter. Come. You got it, huh? No issue. Give another 3,000. He is obese only. Now hold the wire. I will do it 1 minute. 1 minute I will do it. వచ్చిందా వైరు చూడమ్మా ఒకసారి డైనా పెట్టండి కీప్ ద డైనా ఆన్ no you are not pressed. Now hold the wire and advance it. Hold the wire and this one advance. Right. Yeah, good. Here we have to see the wire. Right, good. Yeah, I'll do it. Just you control the wire. That's enough. Brother, show me the catheter in the center. Yeah, that's fine. Just the wire position is under control. I am advancing further. Pull the wire slightly. It is too deep. Slightly pull. Fluoro on. Come. Pull the wire slightly. You only control. Don't. No, pull. Slight pull. Come nearer. Then dyno off. Yeah. Show me the. Yeah, I think this is fine. I'll slightly pull the catheter out, align, then. Okay, now I am going with the. Ready, brother? Okay, I am starting the arbitration with the LM to LCX. Dyna undi. Press. Right. Slow movement. You have to leave it there for some time. Yeah, this is the area. Only 1 to 3 mm forward motion. I think బాగానే moving nicely. ఏమైనా డీకే చేయాలా సార్ డీకే క్రచ్ చేయాలా ఆయన డీకే చేస్తలే బెస్ట్ లాంగ్ టర్మ్ రిజల్ట్స్ ఆర్ బెటర్ కదా ఎక్కడున్నారు పేషెంట్ ఇయ్యాలి కదా షిఫ్ట్ చేసే వరకు అయిపోద్దులేండి రెడీయా I will do 2 runs, then I will go with 120 to 80,000. Ready, brother? Okay, I'll go 120. Bas. ఏమంటారు స్టెంట్సా జైన్స్ విల్ గో విత్ జైన్స్ ఆల్ఫైన్ టేక్ ఆల్ఫైన్ ఏ సార్ no comfortable, this is ideally it can accommodate nicely. Ready? Yes sir, ready sir. 120. ఇంకొక రన్ చేసి ఐల్ కమ్ అవుట్ మళ్ళీ ఐవెస్ రన్ ఐల్ డూ డీకే క్రష్ వెరీ నైస్లీ బికాస్ లాంగ్ టర్మ్ రిజల్ట్స్ ఆర్ బెటర్. ఆల్రెడీ రికార్డ్ చేసిన ఇట్స్ ఎనఫ్. చాలు, దట్స్ ఎనఫ్. బ్రేక్ తీసేయండి, రిమూవ్ ద బ్రేక్, దెన్ డైనా గో టు ద డైనా, ప్రెస్ దిస్. వెయిట్ ఇంకా రాలే. Now it's fine. Now I think Gabe has become expert, orbital specialist. Good. Right, pull out. Push the wire and pull it. Yeah, good. Good. Push the wire, push the wire, push the wire. That's good. You are fine, doing well. Good. Go, proceed. Yeah, continue. Absolutely fine. Go. Yeah. Pull. Yeah, fine. That came out. Give IVS. We'll change the wire. Side let them. Side lo parallelly we'll put the wire. You want to put a micro? Event man, micro event. I'm not dissection like L. Give micro. Now next steps will go faster because we have to do the DK crash, multiple steps, crossing and everything. Give one 3 NC balloon, 3.5 NC balloon. And one stent. We'll avoid that stented portion. Only proximally we'll put the stent. I think 15 enough. 3.5, 15. 3.5 stent. I think 3 should be 3.5. Ready, Amiru? You are ready? Hold the wire. Floro. Hold the wire. Remove it. Why? Pull. No, I think microcatheter is here. You are pulling the micro, I think. No, 1 minute. Okay, mother. Yeah. This is. Angio sculpt, brother. 2 wires. 1 wire into LED, 1. ఇచ్చేయండి ఎన్ని ఇచ్చినా పర్లేదు. ఇది అన్న చెప్తాను. I'll tell you one thing. This is the end. Where is the end? I'll tell you. ఇది ఎండ్ కదా, ఇదే బిగినింగ్ అండి. దట్ ఇస్ ఎండ్. సి ఆల్వేస్ ఇట్లా ఉంది అనుకోండి, సింప్లెస్ట్ ఈస్ ఇట్ విల్ గో ఈజీలీ. సారీ, అందులో ఫింగర్ పెట్టేస్తే వెళ్ళిపోతుంది. ఇప్పుడు ఏషియన్ show wire tip catheter. Yeah, it's okay. Okay, LED wire కూడా తీసుకోండి, తీసేయండి, రిమూవ్. టూ సీసీ మెడాలియన్ హై ప్రెషర్ పెట్. నేను ఓపెన్ చేసినంత మీకు ఈజీ వస్తుంది. రెడీ? అల్లెಲ್ಲ పుష్ 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 పుష్. నో మీరు అట్లా చేయదు. ఓకే, వదిలేండి, ఇన్ఫ్లేషన్ ఇక ఏందో తీసేసిందిలేండి. ఓకే, ఇట్స్ ఓకే, రిమూవ్ ఇట్. ఐల్ ప్లేస్ ఇట్. రిమూవ్. బయటకు వచ్చేసింది కదా మాది. రిమూవ్ దట్. ఎల్లో కాడల్ ఎంగేజ్ కానట్టుంది. ఎల్లో కాడల్ టేబుల్ ఫ్లోరో small test, it is there. Small right, it is there. Wait. Adun. Endlek health and lesedam. Come, give another wire. Brother, give me angio sculpt. 315. Can you go to epicranial? Let me see the distal lady. Wait. Yeah, distal lady. Okay, wire వేసుకుందాం. That's fine. Come, yellow caudal run. Come to yellow caudal. అది వైర్ వచ్చినట్టు ఆల్రెడీ యూ ప్లేస్ వైర్. అదే వచ్చి తీసిన పుల్ చేసిన. పిఏ కాడల్ రా బ్రదర్, పిఏ కాడల్. ఇటు వెళ్ళింది. This is right. I will angioscope చేసేద్దాం ఆల్రెడీ. ఎనఫ్ రన్స్ ఏమంటారు, విల్ డూ అడిక్వేట్లీ బీట్ ఇట్. విల్ టేక్ 1 ఇంజెక్షన్ పోస్ట్ ప్లాక్ మోడిఫికేషన్. యు ఆర్ దేర్. పిఏ కాడలు తీసుకోండి. రెడీ? ఇంజెక్షన్. ఇంజెక్షన్. గుడ్, నైస్లీ ఓపెన్. ఇచ్చేయమ్మా. LCX చేసేద్దాం. ఇచ్చి guide extension catheter, keep it ready. Brother, nearer. Table, center. Do it. Go. 12, 14, 15. Right, deflate. I think that's fine. Do once again. Once again. Deflate. Are they willing to pay DBs? చేద్దాం ఎందుకు స్టెంట్లో కూడా ఓ డీబీ వేసి చేద్దాం ఏమంటారు డూ ఇట్ రైట్ డిఫరెంట్ ఈజ్ ఇట్ బియాండ్ స్టెంట్ నౌ కాదా బియాండ్ స్టెంట్ ఓకే డూ ఇట్ నౌ డిఫ్లేట్ కమ్ అవుట్ రెడీ చిన్న ఇంజెక్షన్ ఇవ్వండి స్మాల్ ఇంజెక్షన్ రెడీ ఇంజెక్ట్ బాగుంది నా ఎల్ఈడి లేషన్ పుట్ ఇట్ సేమ్ బెలూన్ బ్రదర్ కీప్ 148 స్టెంట్ అది విల్ కీప్ 2.75 48 ఆర్ 3 వేద్దామా విల్ ఇంజెక్ట్ అండ్ సి ఇంట్లో కాదు ఎల్ఈడి గో టు ఏపీ క్రేనియల్ దగ్గర రమ్మా వైర్ టిప్ ఎక్కడుంది వైర్ ఓవర్లాప్ అయింది అంటే ఏ క్యాథెటర్ చూపెట్టరా బాబు షో మీద క్యాథెటర్ వైని ఐ థింక్ వీ హ్యావ్ టు పుల్ ద వైర్ ర్యాప్ అరౌండ్ నట్ నవ్ గాన్ గివ్ మీ టిప్ డాక్టర్ సారీ డ్రై గాస్ షో మీ ద డ్రై గాస్ No, it's not going. Brother, give me another Angio sculpt. Let me NC. Give me NC. NC 3. 3 or 2.75. Agent 350 agent. We'll go with NC. After that, we'll pass this one. Right. Give 3 NC. ఆయనకేంటో అడగండి ఎవరైనా ఎవరు మాట్లాడుతున్నారు వై డోంట్ యు టాక్ నౌ ఫ్రమ్ హియర్ స్మాల్ టెస్ట్ ఇంజెక్షన్ ఫ్రమ్ వేర్ వీ హ్యావ్ టు డైలేట్ విల్ డిసైడ్ ఐ ఎంగేజ్ గైడ్ నవ్ సి దట్స్ ఎనఫ్ నా ఇంజెక్ట్ I think correct. We are correct. Do it. Do it. Slow. This is 3, 15. Go slowly. Bas deflate. 48 with the guide extension cat dagger betko. Do it now. And deflate. Do it. Do it. Deflate. Do it. Deflate. Do it. Piya kadalra. Deflate. Come to Piya kadal. I'll push the wire, second wire. That's fine. I'll pull slightly. Do it now. Do it. Deflate. That's fine. No need to do further. Well modified kada.
Balloon is expanded nicely and there is no dumbbell shift.
Give me a stent, brother. 2.75 ఏదో. Give me one guideliner also. Do you have a telescope? Guide plus, give me. Not needed. This is opening well. Faster the better. Come. Brother, give me stent. Now we did the plaque modification, further plaque modification with Angio sculpt, LCX ostium and LED, nicely yielded with 3 mm NC balloon 3 into 15. So proximal to distal we did the further dilatations. Now we are planning to place the LED stent, that is 2.75 into 48 mm Zines expedition. Alpine or expedition? Fluoro? Table. Give me stent fast. Pressure, is it fine? Any damping is there? Some ventriculation is there. If needed, I'll pull, then subsequently we can push it. Yeah, I am keeping here. Now the pressure tracing is good. Okay. Ready? Yeah, I'll hold both. Come nearer, Rama. Brother, show me the stand. Don't do anything. Just I am placing a guideliner. Now epicranial. Now go to epicranial. See, without guideliner we are unable to place it. Now I am advancing this one. Now I am pulling the guideliner. Now give a small injection. It's okay, I think. Shall we come back slightly? Slightly we can come back, I think. Now inject. Now wait. I think fine, Andy. Go ahead. We are perfect. Go ahead. Dilate, implant fast. Implant. Deflate. Deflate. Give once more. Do again. Keep prolonged 20 seconds because calcified vessel. Okay, deflate. I am pulling into the LM higher. I think it's okay. Go higher. You see, nicely expanding. 14, 15. Yeah, deflate. That's enough. Give me 3.5 into 15 mm stent and 3. Inta mundu balloon note undi kada. That is 3. 3.5 balloon give me. Stent also give me 3.5. We'll put 3.5 there. I'll remove the guideliner. 15 enough na? 18 na? Because stent is up to that level. Run. LCX PA cadal. Come. I think stent is up to that level. 15 should be sufficient. 15 even. It is 3.5.
3.5 balloon NC into LED.
Right. Okay, towel, manchi towel yama. Give me towel. Show me that PA cardal ravale. Come to PA card. LCX. I will PA cardala. I will pull and see. This one LCX. We'll keep the wire balloon inside. 3.5 balloon even first. Put the balloon. Parala ichele. Give. Balloon 15 together. Give 15. Come nearer. Come nearer. Now, give balloon. Now we are placing a stent in the L6, covering the proximal edge of the previous stent. This is about 3.5 into 15 mm. We are keeping one more balloon in the LM to LAD because once we implant the stent, we wanted to crush adequately. Come nearer. Lower. Now we are keeping the balloon here. Now small test, Rajaram. You are there? Good, Sini. 1 minute. Yellow card, alra. Come. I can slightly push, I think. Give one injection. No, we are too much, I think. Okay, 1 mm you can push. Small test. Do it, I think. Now it's comfortable. Good injection. Document. Inkocha ravale. Test. Do it. Implant.
Nominal, please.
Do it. Go higher. Deflate. Once again. Deflate. I'll go slightly distally. Dilate now. Distal edge. Dilate. Deflate. This is the stent edge, na? Yeah.
Now it is.
Do it now. Do it. Deflate. Now I am pulling the, always ostium should be adequately dilated. Go higher. Before crushing, ostium of the LCX stent should be opened perfectly. Deflate. Yeah. I am removing the wire and balloon both. Deflated?
Yes, sir.
Now remove. Okay, injection and I will pull the wire also. Before doing table, small test. Test. 1 minute. Ready? Inject. Good. Baundi kada? I will remove that wire and balloon, L6 wire and balloon. This one. I think opposite one. This one. This is the one. And this is the balloon, huh? Okay, that is pulling another wire also. Right. This one. Both are here only. Right. Come, Rajaram, go high pressure. We are across. Go ahead. 1 minute. I will slightly pull the. Go higher. 18, 20. Deflate. Yeah. I will keep here. Epicranial, brother. Yes, sir. I will dilate inside the stent. Table. Dilate slightly. 14. Deflate. Deflated. ఇక్కడ డైలేట్ చేయండి. Deflate. Deflate. డైలేట్. చాలు, అది 3.5. ఓన్లీ 68 చేయండి. అది డిఫ్లేట్ కింద 6 చేయండి. డిఫ్లేటెడ్. ఇంకా రావాలి పుల్ బ్యాక్. డూ ఇట్ ఓన్లీ 6. బస్ డిఫ్లేట్. Give me another wire. ఇంతకుముందే వైర్ ఇవ్వండి. ఇఫ్ దట్ ఈస్ నాట్ క్రాసింగ్ ఐల్ టేక్ ఫిల్టర్. అమ్మ ఒక ఇంజెక్షన్ ఇవ్వండి. గివ్ మీ 1 ఇంజెక్షన్. ఎల్ఈడి లెటర్ సీ డిజిటల్లీ. రెడీ? గుడ్, flowing very nicely. Distally also we will do it, DEB and everything. After that I will do it. Come to PA caudal. Give the second wire, brother. Yeah. You have 1.5 balloon, na, sister? We'll dilate the struts and we'll take 2 3.5s. You have a 2 3.5s kada. Later 3 3.5 I'll do it, don't worry. Bas. Table. Slightly I'll pull the catheter. Yes. Wire pain there, babu. L pain. Right. Give the balloon. 1.5. Now we are doing the first kissing. After first initially we will dilate the struts with the 1.5 balloon. We will take 3 3.5 balloon, 1 into the LED, 1 into the LCX. Clean and other wipe it. These are hydrophilic wires. Now put it. Otherwise I'll pour some water. Ready? Show me. Table. Yeah, dilate amma. Dilate higher, 18 20 20 22 and deflate. Ekkada kuda cheyandi. Avasaram ledhu. We'll take. Go higher and deflate. Give me the both balloons for kissing. 3 give into the LED, 3.5 I'll take into the L6. This is LED. This is LED L6. Next keep brother 3.5 into 18. 4 also fine. 18 or 23 rendu techi pettukondi stents. 3.5 4 both you can keep. If this is not going, I'll use the N. Is L6, sir?
Yes, sir.
Come nearer. Ready? Okay. Fine, Jupiter. Give one more balloon. L6 N balloon 3. 3.5. This is 3. 3.5, huh? Give. If they are not going, we'll see. Just crimp it. Ready? Keep one N balloon ready, brother. Don't open. If required, I'll use it. Table. Gone. Okay. Well, LCX, did we optimize with 3.5? We did. Yeah. Okay. I am pulling that balloon. 1 minute. This is your LED, Kadama? Your LCX, huh? Rajaram, your LED? Yes, sir. I am pulling. You can dilate both. Dilate both, no issue. Dilate. Go. 14. LED should go high. 18. LED 18. 18. Deflate. Once more. LED varu 18, 20 kellandi. Go. Deflate. What is the balloon length, brother? Leave it like that. Give one injection. Let me assess the stent length. Small injection. Inject. Almost. This is balloon length 15, huh? 15. This is touching. We will take 23. We will slightly extend into that. Okay. More safer. What do you feel? Take one. Give me stent, brother. 3.5 into 23 1. I'll find. Small test, Rajaram. బాగుంది కదా నైస్లీ 3.5 వేద్దామా 4 వేద్దామా 4 ఆల్సో ఫైన్ ఆప్షన్ ఓన్లీ 4 నా 3.5 ఇవ్వు 3.5 గివ్ ఎల్ఈడి 3.5 I have to remove the wire. Remind me while implanting the stent. Now already we did the first kissing, that is 3 and 3.5 balloon. 3.5 we kept it in LCX, 3 we kept it in LED. First kissing we performed and crushing was done with 3.5 balloon. Now we are placing a stent from LM to LED. We are using the technique of DK crush. 1 meter, the LCX wire, this one, this is I am removing the LCX wire. Now remove that. Now I am placing the now stent also placed. Eleva cranial, brother. Go to eleva cranial. Wire came out, I think. We have to push it further. Come. I am pulling a small test. Inject. What, man? Keep it center. That's okay. I am doing LM Ashtyan kada. Go to epicranial. Come. No, slightly between elevocranial and epicranial. Don't go too much. Right. Ready for injection? Slightly yellow. Small injection, Rajaram. I think we are slightly yellow cranial inca, still yellow cranial. Small injection, I think 1 minute. Now inject. Go ahead, that's fine. Go ahead. Yes. Come to yellow caudal. A small injection. Inject. And that's fine. Higher. Brother, wait, I want pot balloon. Go. 14. 18 Ellen, 18, 20. Right, deflate. 5 mm pot balloon I want. 5 into 6, fine. Diameter? No, 4.56 level. Small injection ఇవ్వండి. 4.5 enough na? 4.5 enough. అంటే మనం పర్పస్ఫుల్లీ ఆస్టమ్ దగ్గర కొంచెం తగ్గించినాం. 4.5 enough. Brother, come to PA caudal. Show me the stent edge. See, a small test. Well, see there only. Give. Part. ఏంటమ్మా అబ్బాయి దీనికి అవసరం లేదు, దాని తర్వాత వేద్దాం. Come, I'll pull the catheter slightly. Come. కావాలని ఉంచిన అంటే ఎల్ఎస్డి కాకుండా. నెక్స్ట్ బై రెడీ ఉంచుకోండి, రీక్రాసింగ్. షియాన్ బ్లూ. ఓకే. రెడీ? డూ ఇట్. అవసరం లేదు, మనకు బార్డర్ అవపడుతుందా. డూ ఇట్. ఇంకొంచెం ఇటు రావాలి. వీ షుడ్ గో స్లైట్లీ డిస్టల్లీ. డూ ఇట్ నౌ. పర్ఫెక్ట్ ఉన్నాం కదా. స్టెంట్ ఎడ్జ్ ఒకసారి చూసుకుందాం అంతే. డూ హయ్యర్. 18కి వెళ్ళండి. రైట్, డిఫ్లెంట్. బస్, దట్స్ ఎనఫ్. ఇంకా అవసరం లేదు, మనకు స్టెంట్ లేదుగా. అది విత్ రెస్పిరేటరీ మెథడ్ కొంచెం మూవ్ అయింది ఇన్సైడ్ వైల్ ఇంప్లాంటింగ్. ఇట్స్ ఓకే, మనకు యాక్చువల్లీ డిజిటల్ కవర్ చేసిన, దట్స్ ఎనఫ్. స్మాల్. ఒక్క నిమిషం. రైట్, ఇప్పుడు టెస్ట్ చేయండి. గుడ్ సిని. దిస్ ఆల్సో ఫైన్, బాగుంది. ఫ్లోర్ సర్క్వైర్ ఇవ్వండి. లాంగ్ కేసు, ఇట్ టుక్ లాట్ ఆఫ్ టైం. అంటే డీకే తర్వాత ప్లాక్ మాడిపోయి LCX LED. కొంచెం క్యాథర్ మంచిగా పెట్టుకుంటే అల్పుడు క్యాథర్స్ రైట్ ఇవ్వండి. ఎంగేజ్ కావాలి. ఇంకాలే ఇప్పుడే give that balloon, give 1.5 again. Same we'll take now 3.5 and both 3.5s. What do you say? 2 3.5s, brother. Yes, sir. ఇది బెలూన్ ఫ్లోర్ డైలేట్ హయ్యర్ 1820 deflate go 1820 deflate okay give me 3.5 N LCX లకి అండి. ఓ ఎల్ఈడి లకి ఇవ్వండి. దిస్ LCX ఐ థింక్ ఫినిష్ లేండి. లాస్ట్ ఐవర్ చేస్తే సరిపోతుంది. nearer come gone ఇంకోటి ఇవ్వండి. అది కొంచెం క్రిప్ చేయండి. ఫ్లూయిడ్స్ యు ఆర్ కంటిన్యూయింగ్ నా brother? Are you continuing fluids? ఎంత ఉంది? what is the flow rate? At least 50-60 ml per hour maintain చేయండి. come nearer, show me the catheter. Good. What minute? మీరు LCX కదా? 1 minute slightly. Now you can go ahead. 1 minute. LED slightly away ఉన్నట్టుంది. That is LED LCX. No, LCX only. మీది LED కదా? Now go ahead. Okay. Go ahead.
2, 4, 6, 8, 10, 12. Enough.
I'll slightly pull, then you can do both. Deflate.
2, 4.
No, I am pulling, I think LED. This LED, that's one. And now I will pull slightly further both. LED meer kada? Go ahead, both. Go.
Only 12 2, 4, 6, 12.
Deflate. Give me part balloon. IBS కూడా రెడీ చేసుకోమ్మా. Take out, hold it. Brother, check the ACT once, because it's a quite long time. Take out. Show me the wires. Fine. One LCX slightly will pull. This is LCX, no? Right, Bhanan. Okay. We'll do the part and then we'll acquire the image. That 4.5 below. Now we are doing the repart again. Already we did the second kissing. Then we'll acquire the OCT images. Sorry, I was. Come nearer. Fluoro. One minute. Do it there. Do it there. Go. 18. It's a bigger deflate. That's fine. Yeah. Ragmal, the stent. If you want to do the stent boost, you can take, brother. Okay, I think here only, na? Change. Take stent boost. Inka ravala? I think perfect. Okay, let me. Ready, huh? I think 1 mm మీరు అన్నట్టు రావాలేమో. 1 to mm రావాలి. అంతేనా? కొంచెం రావాలి. ఇంకా it will show you have to come slightly. But I think we are perfect అండి. That is above one is the calcium. Do it here only. That's enough. That's enough. That's enough. ఏమంటారు వేణు వాసు? ఐ థింక్ లోయర్ బార్డర్ పర్ఫెక్ట్ ఉన్నాం కదా. ఇంకా ఫ్లేరింగ్ అవుతూ మనకు స్టెంట్ ఇప్పుడు ఇంత ఆస్టియం దెన్ యూ షుడ్ డూ ఫ్లేరింగ్. అదర్వైజ్ వాట్ హ్యాపెన్ ప్రాక్సిమల్ ఎడ్జ్ డిసెక్షన్ విల్ కమ్. గివ్ మీ ఐవస్ క్యాథెటర్. We'll first LCX IVS. మళ్ళీ అదేందుకు చేంజ్ చేశారు? No, why do you experiment? I'll do manual. Give. Don't delay it. Don't delay it. That one you should check early only. In the beginning, if you check, that is different.
LED. First LED post.
Nearer, brother. Rama, Dagaran. Brother, show me the LED. Yeah, that's fine. This is LCX, na? This is LCX LED, yeah. I think LED. Come nearer. Come nearer. Epicranial. I think our stent is up to this level only, I think. Ready, huh? Run. Distally, that's okay. That plaque only small area. This is fine. Our intention. This is also fine. No, the stent is a good landing zone. I am going distally. So we are, yeah, stent nicely expanded. Beautifully expanded. Area is also good. Nicely expanded. I think beautiful expansion. Nothing. Almost 1, 2, 3 mm diameter, vertical as well as. Now I am coming to the ostium of the LED. LED ostium also nicely expanded. This is LM. See, LM almost 1, 2, 3, 4. That's fine. And now take the same into the LCX. Done with Asian. Okay, brother, 1.5 N రియర్ దగ్గర పెట్టుకో 15. రెడీయా? డిజిటల్ వీలైతే విల్ డూ డిజిటల్. కమ్ ఎపికల్ రండి బెటర్. Can you put it? Yeah, I think this is fine. Ready? Yeah? Ready on? You mark it LCX ani. No, distally healthy landing zone. I am pulling healthy landing zone. And this is some plaque is there, but it's fine. And this is also fine. And here also good area. That is previous stented area. Stented area good. And this is also good. Now coming to the present stent overlap. బాగా ఎక్స్పాండ్ అయింది. వెరీ వెల్ ఎక్స్పాండెడ్. దిస్ ఈజ్ LCX RCA. This is also good. There will take area. Now I will see this is the proximal edge of the LM. And there is no proximal edge dissection. Okay. Brother, we have to take the LCX area. If it is 5 square mm above, we leave it. Come to the LCX, move. That eccentric, whether that needs to further modification or that we'll see. Move. I will tell you where to stop. Move. Still, 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 still. Move, move, move. Still. Here you take area. It will be more than 5. Eccentric, but it is more than 4. .27. Good. But that is 8765 square mm. Slightly move. Any other area is smaller. Slightly move that one. Inka move chain. Move. మూవ్ చేయరా బాబు. ఇంకా లెఫ్ట్ మీద దిగి రారాదు. ఇక్కడ చేయండి ఒకటి. ఇయర్ ఆల్సో ఒకటి. అక్కడ అది నీకు ఎల్ఈడి ఓపెన్ అయింది ఎట్లా తెలుస్తుంది? ఇంకో అక్కడ తీసుకోండి. అదే మళ్ళీ సేమ్ ప్లేస్ పెట్టండి. గ్రూప్ ఆఫ్ ఎక్స్పర్ట్స్. ఇంకా ఇటు రండి. యూ కమ్ దిస్ సైడ్ లెఫ్ట్. ఇంకా ఓకే తీసుకో అల్సి. No, అందులోకైతే ఇన్సైడ్ నేను అన్నది ఇక్కడ రా బాబు. నువ్వు అది తీసేయండి. అది ఇన్సైడ్ అని మూవ్ ఇన్సైడ్. 6 ఉంది. ఓకే లీవ్ ఇట్. అంటే యాక్చువల్లీ దిస్ సైడ్ ఉంది. ఇట్ విల్ బి మోర్ దాన్ 6. ఐ థింక్ నో నీడ్ టు డూ ఎనీథింగ్. వి లీవ్ ఇట్. దెన్ షో మీ ది డిజిటల్ ఎల్ఈడి వన్స్. షో మీ ద డిజిటల్ ఎల్ఈడి వన్స్. ఎపిక్రేనియల్. చూస్తాను నమ్మను. కాన్సన్ట్రేట్ ఓన్లీ ఆన్ ద డిస్టల్ లేడీ. టేబుల్ డిస్టల్ లేడీ అన్నా కదా. గిడ్ ఇంజెక్షన్. రెడీయా మీరు? ఇంజెక్ట్. ఫ్లోర్ మీరు సరిగ్గా ఎంగేజ్ కానట్టుంది. ఎల్లో కలర్ రండి. ఎల్లో 1 minute ఇంజెక్ట్. అదే ఎంగేజ్ కాలే అంత గురించి. ఎప్పుడు చూడండి. నవ్ గో టు ది ఏపిక్రేనియల్. ఏపిక్రేనియల్ కాన్సన్ట్రేట్ ఆన్ డిస్టల్ లేడీ. టేబుల్ ఇక్కడ కాన్సన్ట్రేట్ చేయండి. ఓకే, రెడీ. ఇంజెక్ట్. ఐ థింక్ ఒక 1.5 తోటి డైలేట్ చేసేద్దాం ఉన్నది. బట్ దట్ ఈస్ ద రీజన్ వీ హ్యావ్ టు డూ సచ్ కేసెస్ ఓన్లీ. ఐ విల్ పుల్. దిస్ ఇస్ ద వన్ కదా లేడీ. ఇది 1 minute. ఇప్పుడు ఇంజెక్ట్ చేయండి, నేను చెప్తాను. గివ్ ఇంజెక్షన్, యూ విల్ అండర్స్టాండ్ వెరీ క్లియర్లీ. 1.5 NBL ఉన్నాయి బ్రదర్. సి దెర్ ఇస్ ఎ టైట్ లీషన్. అదే మన 1.5 తోటి చిన్న అన్నాను. ఏం కాదులేండి. ఇట్ విల్ ఓపెన్. ఇట్ విల్ ఓపెన్ నైస్లీ. ఈ వైర్ తీసేస్తే LCX ఎడిషన్. ఇది ఇప్పుడు ఇవ్వండి. ఎస్సిటీ శాంపుల్ అట్ ఇవ్వండి. గివ్ బెలూన్ ఇవ్వమ్మా. ఒక డిఈబి యూజ్ చేయొచ్చు అడుగు. మన ఐవీఎల్ యూజ్ చేయలే కదా. ఐవీఎల్ చెప్పారు కదా. గివ్ డిఈబి ఏం పర్లేదు. ఐవీఎల్ యూజ్ చేయలే కదా. దట్స్ 2 into 18, 20 అట్లా ఇవ్వండి. మీ 1.5 బెలూన్ ఉందా? తీసుకో బెలూన్ తీసుకో ఫస్ట్. అత్త సార్ డిస్టల్ ఈ స్లైట్ ఓపెన్ చేస్తా. 1.5 బెలూన్ తోటి ఓపెన్ చేసి ఇఫ్ నీడెడ్ ఐ విల్ పుట్ డిఈబి. చాలా బాగుంది, మంచిగా వచ్చింది అంతా. ఎందుకంటే టైట్ లీజన్ ఉంది సార్ ఆడ, వెరీ టైట్ లీషన్. బెటర్ టు ఓపెన్ ఇట్. కమ్ బెలూన్ డిలే మనం తొందరగా ఫినిష్ చేసేద్దాం. అదంతా అవసరం లేదు, లీవ్ ఇట్. ఈ ఆటో అంటున్న ట్రాన్స్మిషన్ నా రీసెంట్ స్టడీస్ నో బెనిఫిట్, మోర్ ప్రోకోగ్లెంట్. ఏమ్మా లాస్ట్ వ్యూ చూపెట్టావా బ్రదర్? షో మీ ద లాస్ట్ వ్యూ. గివ్ మీ 2 mm ఇంటూ లాంగెస్ట్ బెలూన్. 35 అట్లా తీసుకోండి. రెడీ అమ్మా? డిజిటల్ ఎంత ఉంటుంది యూజ్ చేద్దాం. కమ్ నియరర్ చూసారా? ఎన్నో చెబోతలే ఇప్పుడు తప్పలీజన్. డైలేట్ చేయండి. ఇక్కడ ఐ టెల్ యూ. డైలేట్. డూ ఇట్. డిఫ్లేట్. Deflated, do it again. Deflate. Deflated, do it again. Wire it in the small branch, it's okay. And now do it. Deflate. Do again. 18, 20. 2 into 35. Deflate. Do it. 2 into 30. Deflate. Do it. చాలు. డిఫ్లేట్. డిఫ్లేట్. ఇప్పుడు చూడండి, మీకు వ్యూ బాగా వస్తుంది. Take one Sini. Rajaram, ready? Bhavun Judan. Now give 2 mm balloon, just will do DEB and come out. That's enough. Even give 2. No, POBA results are not good. DEB definitely, drug is delivered. Very distal. 2 mm we have distal lesion, diffuse lesion, and small segments, small diffuse, small caliber wells, so DEB best. Hold it. Come nearer. That's fine. Okay, na? Go ahead. 6 maintain 1 minute. You can go 8 also, because it will be slightly bigger diameter. 2 times you apply. So distally we prepared the lesion with 1.5 balloon. Our intention to provide even a flow to the distal LAD segment. So there is a very critical lesion. Even while passing the distal lesion also grating sensation was there, but we wanted to maintain some little patency of the LAD, and then little patency of the LAD. So that is the reason 1.5 up to 18, that will come to up to 2 mm. Then we did the 2 mm balloon DEB inflations, that is 1 minute inflations, 6 atmospheres twice. 1 minute over, deflate. We'll give one more inflation. So ideally the DEB as of now strongly recommended to a small side branches and diffuse long lesions, distal lesions and ISR lesions. So if the ISR is there, then fibrotic lesion, cutting balloon or plaque modification, use the DEB. Particularly when there is a multiple layers of stents, and the results are much more superior compared to readers. And the distal LAD lesion, diffuse lesion, diffuse long lesion. So here we thought of giving a additional benefit by giving a DEB application. What is the ACT? Give 3000. Give 3000. No issue. Now radial only give. The advantage of the radial, the bleeding complications are less. He is obese man, and severe disease, right coronary, CTO, that also we did through the right radial approach, and LCX LMCA, very diffuse disease. We did the plaque modification using the orbital atherectomy. LAD, LM2 LAD, we did the plaque modification using orbital. Then LCX also we did the plaque modification orbital. We performed the imaging through the using the IVUS, and while placing LAD also we LAD stent we face a difficulty. We use the guideliner. So all complex procedures can be performed through the radial approach. So a left main decay crush we did with plaque modification, and see bleeding is less if they are femoral and like a 75-year-old obesity is there. The maximum rival study, matrix study, if you see, the maximum complication rate is due to the access complications. So that is the reason MACE rate is much more in femoral versus radial. So over na? One. Yeah, that's fine. I am removing it. I will pull the slightly wire, and then you take the image how the distal LAD looks. Fluoro, and take one small injection, good injection. Engaged. Ready? Adu ikkada chupetandi. Show. See, so we will engage slightly. Hello. show the LO. A small test. And now go to the epicranial top to bottom show, entire LED. I will slightly pull the wire. Ready? Brother? Yes, sir. Ready? Show me. Wonderful result. You see the LED, distal LED, nicely flowing, entire disease, so many septals, so many diagonals, all branches are flowing well. Even distal LED with DEB, extremely good result. Piacardal. Yeah. See, stent expansion is very good with arbitral atherectomy. That is the advantage of plaque modification. Show me the entire LCX now. Ready? Huh? Enter LCX concentrate. See, now LCX also flowing very well. Take one epicranial, then we'll finish the case. Table. Ready? Bas. Good. I think this is a wonderful case where put the wire and remove it. To summarize this case, patient came with a severe triple vessel disease, previously underwent PCF LED, LCX and RCA. Last stent was implanted in 2018 and now presented with recent onset of angina. 10 days back, the CTO of the right coronary was opened using filter XT and plaque modification using the Angio sculpt and cutting and open NC. And the stent is nicely expanded. We implanted 2 stents. That time is Nagomi stents. And now this time LCX, initially what we thought angiography LED is not that significant. Our initial plan was to do the LM to LCX stenting and if needed LED stenting like a T-tap. But while passing the IVUS catheter, we were unable to place the IVUS catheter with a lot of greeting sensation by what we thought it a very severe disease. So we took the proximal LED IVUS study, very severe calcium, dense calcium, more than 300 degree. Then what we thought it has to be done. So what we did, we put the Viper wire using the microcatheter. We did the adequate plaque modification LM to LED up to the distal LED, and then we did the plaque modification of the LCX. We used 48 into 2.75 mm stent of the distal LED to proximal LED, and then we did the LCX stenting, that is using 3.5 into 18 mm stent, 15 mm stent. We crushed the stent, keeping the balloon in the LM to LED, and subsequently we pulled the balloon and ostium also slightly opened further, then crushed with 3.5 balloon LM to LED, and we recrossed. We did the first kissing after crushing the LCX stent, 3.5 balloon into the LCX, 3 balloon into the LED. Then we placed 3.5 into 18 mm, 23 mm stent, extending from overlapping the previously implanted LED stent up to the almost 2/3 of the LM. LM is short, so proximal ostial LM is not diseased. So then after that we recrossed. Part was performed. Part was performed using 4.5 into 6 mm part balloon. Then recrossed the LCX struts, opened with 1.5 balloon. We placed 3.5 into 15 mm balloon to LCX, 3.5 into 15 into the LED. Kissing was done. Post kissing, angio was done, I was done, nicely expanded stent. LED area is more than 7 square mm. LCX is almost 5.5 square mm. LM area more than 14 square mm. So all areas as per the guidelines adequately expanded without any malopposition, without any edge dissection. And final view showed distal LED diffuse disease with critical area of narrowing. What we thought, okay, diffuse long lesion. Then we used 1 point balloon, high pressure inflations, and then used 2 mm into 35 magic touch balloon. Then we delivered the DEB. And finally you can see the imaging of the distal LED. The stent is nicely expanded, distal LED lesion is cleared with DEB and balloon modification, and the LCX is flowing well. And I think this is a wonderful case. This is a thank you all of you for joining. We wanted to showcase the IVUS guided plaque modification of the LMCA using the DK crust stenting technique. Thank you. Let me again introduce my colleagues, wonderful colleagues, Dr. Kavya and Dr. Rajaram and Vasu and Venu, technicians. So thank you all of you for paying attention. We'll come back to you again with another interesting case. Thank you one and all. నేను మర్చిపోతున్నా నీ పేరేంటమ్మా